Welcome to Atlas, Modules for Orthopedic Education. Today our topic will be sports and we'll be covering knee injuries. Let's get started with our case. A 21-year-old female soccer player was running during practice when she abruptly changed directions while following her teammate's pass. She felt a pop and immediately experienced sharp pain deep within her right knee. She fell, grasped the knee, and within seconds it began to swell with fluid. She was apprehensive to bear weight on the affected leg and had to be removed from the field with the help of her teammates. There are some classic elements to this HPI that point us towards a single diagnosis, and let me highlight those for you. 21-year-old female soccer player, abruptly changed directions, felt a pop, knee began to swell with fluid, and was removed from the field. These elements are all classic for our topic of the day, which is ACL injury. Quick outline, this will be a 15-minute presentation intended for medical students interested in boosting their ward performance, interns in primary care reviewing for clinic and the boards. There will be three major parts: epidemiology and presentation, labs and testing, and we'll conclude with principles of therapy. Our goals for you at the end of this session are to be able to rule out other diagnoses that present similarly, order cost-effective tests, and plan effective therapy. As always in our modules, we'll learn in the great tradition of medicine from our patients through case-based learning. So let's return to our patient, a 21-year-old female soccer player. First identifying element of an HPI, you might be wondering, were there things that placed our patient at increased risk for an ACL rupture? To answer that question, we need to learn more about epidemiology. Baseline for context, the incidence of ACL rupture is 1 in 3,500 in the general population. The prevalence is 100,000 to 200,000, and there are known risk factors. Gender is one of those risk factors. Women have a several-fold increased risk of ACL rupture. The specific magnitude depends on the sport in question, the paper you're looking at, and this increased risk is thought to occur due to a variety of factors, including differences in gait, differences in dominance of the quadriceps group versus the posterior hamstring group, and possibly other factors. The typical age for presentation is late teens and early 20s. And this is a sports lecture, so let's talk sports. In women, the two sports that are most commonly associated with ACL injury are soccer and basketball. Female gymnasts technically have the highest rate per event, but in clinic, you're much more likely to see a soccer player or a basketball player. Interestingly, dancers may have a lower rate compared to field counterparts due to balance training. So returning to our patient, we can see that she's the right age, 21 years old, to be at increased risk for this. She's a woman, which places her at increased risk, and she's playing a sport that is known to be associated with this kind of injury. We also know that her knee began to swell with fluid when this event happened. So using our knowledge of anatomy and physiology, let's see if we can provide some insights into elements of the presentation. For each finding, we're going to discuss proposed mechanisms. Let's start with the classic one, immediate swelling. This is thought to occur due to hemarthrosis. There's arterial blood, which extravasates from branches of the medial geniculate, which supplies the ACL, and blood is irritating to the synovium, produces inflammation. There's your swelling. The pop is another common feature. There are two proposed mechanisms for that. One is the tear of the ligament itself. The ACL can withstand or tolerate several thousand newtons worth of force, and like a leash, when it snaps, produces a sound. She was removed from the field. How would you examine her if you were there on the sidelines? As you might recall, when you do any physical exam, there are classic elements: inspection, palpation, testing range of motion, and assessing strength and neurovascular status. So for each of these, what would we expect? When we inspect in the acute setting, we'd find ecchymosis, swelling, and erythema. On palpation, there would be tenderness and effusion. Range of motion is often limited by the pain and inflammation. Similarly, strength is often limited. As far as neurovascular status, we test sensation in the leg and the thigh, and the relevant pulses to check would include the popliteal, tibialis posterior, and dorsalis pedis for a complete exam. And there are maneuvers we can perform immediately to inform our clinical impression. The most important of these is the Lachman's test, which is superior to an anterior drawer test, a big take-home from this presentation. A pivot shift is a physiologic maneuver that's often performed under anesthesia, and in the literature you'll see quantitative measures such as the KT-1000. Let's take a look at some pictures to inform this discussion. On inspection, you'll often see swelling, and on palpation there will be tenderness, so we'll turn to our first maneuver, the pivot shift test. In this test, what happens is that the provider exerts a valgus stress on the knee, L for valgus, while extending the knee simultaneously. This is a very physiologic motion. We think this is what actually causes the rupture in cases of ACL injury. However, it's very painful, and if you don't have access to anesthesia, you may not be able to perform this test. So fortunately, we have another tool in our box, and that's the Lachman's test. In this test, you can see that the provider is exerting a posteriorly stabilizing force on the femur while pulling the tibia anteriorly. A negative test, it'll feel taut and firm. If the ACL is ruptured, however, there will be laxity. This test can be very sensitive, very specific, and it'll add to your diagnostic reasoning. The two biggest tests in orthopedic imaging are the X-ray and the MRI. Let's consider each of these for an ACL rupture. When ordering any imaging test, you want to consider what views do you want, what findings are you looking for, and how much it's going to cost. So for an X-ray of the knee, you want an anterior, a lateral, and what's called a skyline view. That'll allow you to get an appreciation of how the knee joint is doing and also how the patella is doing. The finding you're looking for in an ACL tear is called a Sagoon fracture. It's kind of subtle, but we'll take a look at it. An experienced radiologist might be able to detect a fusion or rule out tibial plateau fracture. X-rays are pretty cheap. They cost about $90. An MRI of the knee, that's the gold standard. And the views you're going to get with that are sagittal and axial. The findings that you'll get, the pathognomic finding is actually what's called a bone bruise pattern. This is thought to occur when the posterior of the tibia makes contact with the anterior of the femur. Only happens in an ACL deficient knee, and that's classic. It's actually hard to visualize the tear sometimes because a true sagittal plane doesn't run in the same direction as the ACL ligament. There has been some modification of imaging technique that'll allow better visualization. However, that's beyond the scope of this lecture. You might also notice concurrent meniscal pathology, and that'll be a big deal when we're planning out what operations we want to get for the patient. However, all this information doesn't come without a price tag. MRIs cost several $1,000s. My source for these numbers was Medical Blue Book, which cites $1,200, but it can be several times that amount. Let's take a look at a few examples. We've stepped into the dark room, and we're taking a look at a picture of the knee. First question you should ask yourself, is there a finding? And I can tell you there is. Can you see it? Yes, there is a Sagoon fracture, and the arrow directs you right to it. The first time I took a look at this, it was a little hard to see, so let's take a closer look. Can you see the avulsed piece of bone now? It's fine if you can't. These things take practice. Let me highlight it for you. Excellent. So we already have a suspicion for the ACL rupture with this X-ray. We're going to follow up with an MRI. We're going to take a look at a few examples. Immediately in the middle of the knee, you can see a flap or a white line, and that represents meniscal injury. Also in this image, there is a bone bruise pattern shown by the red stars. And this knee is also, of course, ACL deficient. Let's try another example. Can you spot the bone bruise pattern? Yes. The bone bruises are right there. And of course, there's ACL deficiency. There are other findings, but they're beyond the scope of this presentation. In our 21-year-old soccer player, we've established the diagnosis of an ACL rupture, so now what are we going to do about it? There are two approaches. There's non-operative, which involves a little bit of medical therapy, but mostly intense physical therapy, and there are also operative options. Let's dive into those. With any musculoskeletal injury, there's rest, ice, compression, and elevation. The classic mnemonic RICE. You're going to use NSAIDs to reduce inflammation. Use these with caution in people with renal difficulties. So your patient, she asks you, if I don't get surgery, how long will it take me to recover and get back on the field? With a non-operative approach, there are some principles that dictate how people progress. The goal is to preserve range of motion, particularly on extension, build muscular strength to protect other structures of the knee, particularly the soft structures. And this takes weeks, often 12 weeks or more, though it varies from individuals. A experienced physical therapist is going to use performance milestones to dictate how quickly or how slowly a person moves. However, you can roughly divide rehab into 3 phases. The first 3 weeks are usually devoted to taking it easy on the knee, protecting it, but also preserving range of motion, because with reduced activity, the joint can become frozen or fibrotic, so to say. In weeks 4 to 8, you focus on general strength building and return to some activity. And finally, in the last phase, in weeks 9 to 12, the goal is to return to sport. So there are more exercises that the physical therapist gears specifically towards the sport in question. Though the outcomes are often satisfactory for people who aren't very active, instability will still limit function in many high-level athletes and just active individuals. You tell this to your patient, she tells you, I think I want surgery. With any surgery, as with any treatment in medicine, there are indications and contraindications. You should know for ACL reconstruction, there are no absolute indications. However, there's some relative indications that can guide us in terms of choosing whether or not we get this therapy. High activity athletes, particularly those in cutting and maneuvering sports, if there are episodes of recurrent instability, clinically, if we see concomitant ligament injury that's persuasive to the repair because there's some evidence that there could be more extensive soft tissue damage without repair, and unstable vertical meniscal tears. Of course, there are also things that are going to make us slow down. And what are some examples of those? If there's infection, we will not proceed with operation. If there's fracture, that needs to be addressed. If there's neurovascular compromise, that's an emergency, and we have to take care of that first. And of course, open wounds around the knee are going to increase the risk of infection. Finally, post-op rehab is also a consideration. For a lot of people, there are psychosocial barriers to accessing the care, and some people simply may not care for it. There are other considerations too. The truth is, without an ACL, you can do many, if not most, activities. You can walk upstairs, you can walk on the street, you can climb, you can do many low-demand activities and even high-level activities that don't require rapid changes in direction. The clinical thinking used to be that older individuals were not candidates for the surgery, but that's shifted. Now the thinking is that active older individuals could see the benefits of surgery. And finally, you should always consider the psychosocial factors. For some individuals, this might be a weekend warrior type sport, not something that's central to their identity, to their life, or their community members. For other people, for example, our soccer player, maybe she's played since age 4, and having confidence in her legs, which she's relied on so much for such an important part of her life, is something that's going to be important to her. This is part of the art of medicine. Of course, when discussing any operation with the patient, we do have to consider complications. Campbell's Operative Orthopedics, one of the classic texts in ortho, divides analyzing complications into preoperative, intraoperative, and postoperative. Let's consider them in that fashion. Timing is one of the important preoperative considerations. Earlier intervention means earlier return to sport, better performance, and lower risk of osteoarthritic change. There's also some degree of conditioning that has to happen before someone's ready for the OR. In the OR, complications can happen despite our best efforts. There's some general risks associated with any surgery. With induction of anesthesia, people may have an adverse reaction. There's a risk of infection, though with ACL repair that is low. There's a risk of bleeding, though with ACL repair that risk is low. Then there's some complications that are very specific to this operation. You'll hear the phrase damage to surrounding structures, and you might be asked, what are those surrounding structures? There are a lot of other ligaments in the knee that can be injured during introduction of arthroscopic instruments. And there can also be patellar fracture. Furthermore, in orthopedics, there's always a concern for sizing error. The graft might be too long or too short. And one of the factors that requires the most experience, judgment, and technical skill is positioning of the tunnel. And the most serious complications tend to occur, of the complications that do occur due to femoral tunnel malposition. Postoperatively, anterior knee pain is a common complaint, occurs in anywhere from 0 to 34% of people. The mechanism is unknown. The other major complication is limited range of motion on extension. Occurs in 1 to 13% of people. That's thought to occur due to tunnel malposition, particularly the femoral tunnel. If the tunnel is angled too vertically, it'll limit rotational stability. And if it's placed too anteriorly, it'll limit flexion. The final complication, of course, is graft failure, which we will consider later. Immediately after the operation, if you're caring for this patient, the two major goals are pain and infection control. Pain, often with the minimally invasive procedure, is the one that requires a little more vigilance. During rehab, it may last 6 months or more. There's going to be a transition from closed chain exercises to a sports-specific regimen under close supervision of a physical therapist and the whole sports medicine team. So finally, we've done all of this. What are the outcomes? Let's start with the good. There's a 90 to 95% restoration of stability per the K1000 test, higher functional scores, and earlier surgery is typically associated with better outcomes. But it's not all good news. Graft failure is something that both surgeons and patients worry about. It's reported in about 0.7 to 8% of patients specifically as instability. However, you'll see it cited more frequently in a vague or broad sense in 1 in 10 to 1 in 4 people. Whenever this happens, we try and figure out what was the reason. As a rule of thumb, early failure or failure before 6 months often occurs due to technical error or overly aggressive rehab. After 1 year, it's often due to re-injury. These are active people who love what they do. That's always a possibility, though the grafts typically have a greater strength than the native tissue, at least in some ranges of joint motion. What you should keep in mind, however, is in practice, often the cause may not be determined and it could be multifactorial. And what's uglier, at least for now, there's a serious and contentious debate as to whether reconstruction is a protective factor or a risk factor for osteoarthritis. Those who argue that it's a protective factor cite that restoration of the ligament provides more anatomic and physiologic function and reduces stress on other structures. However, other experts have argued that repairing the ACL is just a license to return to some of these higher risk activities, and it could increase the risk for osteoarthritis. as I mentioned, this is a hotly debated topic, and something that, as every provider, you have to reach your own conclusion about. Thank you for listening, and stay tuned if you want some additional discussion of surgical technique. If you feel that you've mastered the material for this ACL module, try our sample case. Thanks for listening.